Hello, welcome. I really feel bad. I just cut off a Bruce Springsteen song. I think that's from Born to Run, which is pretty sad that I remember that. Welcome. We got one more panelist, Lisa. And then we're going to get started. Keith, can I just move this thing? Will something happen if I move it? Okay. I just wanted to make sure. Okay. Well, welcome to Suicide Prevention and Awareness. We've got a great panel today, which I am looking forward to hearing from. We're going to do some quick introductions, and then we're going to dive in if that works. I can't actually see your name tag, so if not your name tags, your names. So we're just going to start at the top. First, I'd like to introduce Dr. Lisa. So she is employed with Crosspoint Human Services. She's a faculty member at Central State University in Ohio, master's degree in school psychology, and a PhD in clinical psychology. So welcome. We have Sarah Nixon, who is here, a clinical social worker who works with the VA health system, and she is here. She has been with the suicide prevention team for the past 4 years and provides case management services to veterans who are at high risk of suicide. So welcome her as well. Down at the end, we have Jim Russell. He's the executive director of the Vermilion County Mental Health 708 Board. He is a licensed clinical professional counselor and is a certified instructor for the mental health first aid. He's in both therapy and supervision roles, a substitute teacher for approximately 10 years, and a volunteer EMT. Benita, hello, down there next to Jim, has been employed with Rosecrance Hospital System for 17 years. She has a bachelor's degree in business education. She's earned a master's degree also in business education, and she also holds a Master's of Social Work and is a licensed social worker. Zachary is a licensed clinical social worker here in town who attended the University of Illinois for his undergraduate, received his MSW degree from Simmons College, and he focuses on trauma, PTSD, and certified in trauma-focused cognitive behavioral therapy, works with depression, mood disorders, and he provides individual, couple, and family therapy. Wow, you guys got a lot of stuff. So awesome. We have Laura with us. She is a former TRIO advisor. She's from the Chicago area. She lives in Urbana. She works for, I'm going to get this one correct this time. Don't. Cummins. And is that right? Cummins? Cunningham, every time. This is what I get for having thought I got it. She holds a master's degree in social worker, master's degree in social work. And then Stephanie Potts, who is our chief diversity officer here at DACC. She is the director of student services, and she has been with the college for the past 12 years. Is that accurate? A little more than that? Okay. 12 plus years. All right. We have Jan here, who is our coroner in Danville. She is served on the police department for 22 years. She is also an Army veteran.
Right. Yeah. You don't have to read all that other stuff.
Okay. It's like 4 pages.
Yeah, you can skip it.
And then
Step
we
on my
have Sasha,
education.
who is a nurse practitioner and assistant medical director at Two Roads Wellness Clinic here in Danville. And practices integrative care. So welcome our panelists. I am John, so nice to meet you. Thank you for coming out. And we're just going to dive in, if that's okay. That work? All right. So I'm going to start with Jan, if that's okay, our coroner. I have recently reviewed the I-Plan for Vermilion County. It looks at all of our health statistics, suicide statistics. Has there been changes in increases or decreases in?
I would say increases in our suicides and our drug overdoses in the last 3 years. So far this year, we've had 14 suicides. Had another one last night, so I'm a little tired. But we have a problem here with drug addiction and with mental health crises here in Vermilion County. The preeminent or the prevailing mode of suicide is gunshot wound, even for women, because classically, when I started in law enforcement almost 30 years ago, women didn't use a handgun, and now they do. So yeah, we've had 8 gunshot wounds, hanging, asphyxiation, 2 drug overdoses, and a blunt force trauma from walking on the highway for suicides this year. So there's a problem here, and we're not isolated, and we're not an anomaly. It's that's the trend all over the state and pretty much across the United States.
So we're seeing the increases across the country. Okay. All right. Well, I have a question that I'm going to kind of throw out to everyone, and feel free to jump in every time I go to.
What did he say?
All right. So basically this question for all of you guys, we have obviously a wealth of experiences, different agencies. So the question I kind of throw out is, what role does your organization, program, or occupation play in prevention, intervention, and social awareness regarding suicide awareness and prevention?
Do you want to start at one end of the table and work to the other?
Yeah, we can. Dr. Lisa, would you like to start? That would be fine with me.
I'll be more than happy to start. So I am Dr. Lisa. I'm a psychologist, and I am at CrossPoint. And at CrossPoint, we have a variety of services, but one of the areas that I'm very proud to speak to you all about is our crisis services. I've been in Vermilion County now for about 1.5 years, and I'm learning that many individuals in the community have no idea about all of the services at CrossPoint. So we do have a crisis line that's 24/7 for individuals in the area that they can call if there is a crisis, that they're experiencing. We also have mental health recovery services, so that's where I am the supervisor. And Zoe here is one of our therapists in the mental health recovery services. We have medical residential services. We also have developmental disability services, an early learning center. So as you can hear, a lot of different services for the community. However, if you do know of someone who may want to in their lives, we do have a 24-hour, 7-day-a-week line that you can call on their behalf, but then you can also have them call as well. Thank you.
Well, I went from being a first responder to a last responder, so you don't think I have much to offer on that. But when I took office, I decided that I needed to do fatality prevention. And one of them is drug addiction and awareness, substance abuse, and suicide prevention, and traffic crash fatalities. They're probably the only 3 things that we can do anything about. I can't make people go to the doctor. I can't make people take their medicines. I can't make people eat healthy and lose weight. But, if I can push out statistics, I teach defensive driving out here at DAC for traffic fatalities. I've been here, actually, I teach in criminal justice also here, and I've been here almost 20 years. So if I can assist other agencies such as CrossPoints and the 708 Board with Mr. Russell and the Health Department, Rosecrans, with gathering statistical data that may help them tailor programs specific to our community, and that's basically what I can do. I know it doesn't look like a lot, but I do a lot of statistical information and reports to send out to the health department and to our local agencies.
Good morning, everybody. My name is Zach. I'm with Illume Counseling and Wellness. So we're an outpatient clinic, and so what that means for us when it comes to suicide is we are constantly evaluating our patients. So when a patient comes in, it's the therapist's responsibility to determine level of risk. So I will just ask my patients, are you feeling suicidal? We speak very openly about suicidal ideations. When a patient is actively at risk of harming themselves, we take action, whether that is safety planning, intensive outpatient programs, or inpatient psychiatric hospitalization. That is often achieved through the emergency room, which is unfortunate, but that's ultimately the most efficient route of getting someone who is at risk of harming themselves into the hospital.
I'm Sasha from Two Roads Wellness Clinic, and we offer traditional mental health therapy services as well, which incorporates assessment for every patient for like depression and the kind of underlying cues for risk of suicide. We also have nurse practitioners who prescribe medication to actually treat some of those underlying things, to hopefully, if you can treat prevention or treat depression, you can prevent some of that suicide risk. I personally do genetic analysis for people, so we can actually see there are very distinct cues for risk of suicide, like low COMT and your risk for depression, your risk for bipolar disorder, actually having dopamine receptors that don't function well, and then specific traits of your personality like aggression and impulsivity and risk for addictive behaviors. So I look at your actual genetic analysis to see if you have any of those risks, because that means that you may need more intensive intervention or treatment or evaluation when we follow up on your questionnaires or with your therapist. So we kind of work collaboratively. I do the background genetic stuff and then talk to your therapist and talk to the person providing your medication to make sure that everyone is taken care of from every angle, so we can try to reduce the risk as much as possible.
And I'm Stephanie Potts. I'm here on DAC's campus at the Advisement and Counseling Office, and we offer short-term crisis intervention. We have 2 counselors on campus. I'm one of them. We also work with CrossPoint to have a licensed therapist come in every Wednesday and Thursday from 10 to 1. So we do focus on prevention, we focus on intervention, doing things like this to increase the social awareness. So I think that's my part.
Hi, I'm Sarah. I'm a social worker at the VA. So I'm specifically in the suicide prevention program. Because veterans are disproportionately affected by suicide at a higher rate than non-veteran U.S. adults, suicide prevention has been and remains the #1 clinical priority at VA. So our program in particular provides outreach. So we know that not all veterans receive services at VA. So veterans that are in crisis, while we may not see them, they may, community partners like firefighters, police, EMS, hospitals, may come into contact with them. So we outreach all 30 counties in our catchment area to try to really educate everyone on the risks for suicide and to recognize the warning signs and then know what to do if they spot those. We provide education within VA on suicide, and in the community we provide that same education. And then we, within our program, provide case management services to veterans who are identified at being at higher risk for suicide. So we're doing frequent check-ins. We're making sure that if they no-show a mental health appointment, there is significant follow-up to check to see if they're doing okay. The VA has also implemented a standardized risk assessment to screen every veteran at least annually for suicide risk. They have developed a new position within VA called the Community Engagement and Partnerships Coordinator position. And that person's whole job is to develop community coalitions to help battle this epidemic of suicide in communities. They've also developed a Reach Vet program within VA, so every month we get a list of veterans who, somebody much smarter than me came up with some algorithm, and they look at a ton of factors. So diagnosis, medications, hospitalizations, et cetera, and it gives us a list every month of the highest 0.1% veterans who may be at risk at our facility, and we reach out to those veterans. We also do a gatekeeper, SAVE, or suicide prevention training for every new employee at the VA. So we're always trying to be innovative and creative and address it from all areas.
It's me. Can everyone hear me? Yeah, okay. My name is Laura Reed-Salee. Again, I work for Cunningham Children's Home. Specifically, I am a family therapist, so I do a lot of direct practice work with youth and families across youth within 4 counties, so Vermilion County, Ford County, Iroquois County, and Champaign County. I also supervise our intensive placement stabilization program, bachelor's level family support specialists, our Family Stronger Together program, bachelor's level family support specialists, and supervise our vocational options program. Specifically, as it relates to intervention and prevention, so what that looks like in my role as a family therapist is working with youth and their caregivers to develop a comprehensive safety plan, crisis plan in support of identifying their individual triggers, also in support of identifying what specific coping strategies have been beneficial to help minimize their risk of escalation. Also, really supporting them in their development of new skills, or youth who have had history of suicidality or self-harm behaviors, supporting them in developing skills related to replacement strategies that may help in the moment. And then also, as it relates to engaging youth and caregivers, we really believe in creating a culture of collaboration, and so working collaboratively with them to exercise healthy curiosity. So about how and why they experience certain triggers, and again, in support of them learning, about what it is that's going to best support them in the moment of crisis. Supporting caregivers and understanding that their expectation is not that they operate as experts in assessing safety risk, but we really try to support them in really developing their attunement to the youth and their care, to support the increased likelihood that they'll be able to recognize when their child is experiencing psychological distress. Also, intervention in the form of creating that individualized safety plan not only includes identifying triggers and warning signs, so what it looks like when the youth and their care experience distress, also specifically identifying support persons, so whether that's natural supports or specific providers within the community that can provide more intensive support and care, making sure that they have an awareness of who, those persons are, and whom they can, access in periods of crisis. And then also exploring the ways that caregivers can work to make the immediate environment safe. So helping to reduce youth's access to different items that they may utilize for self-harm has been really important. And then at the community level, I would say that really helping to support bridging the gap between families and the utilization of the professional resources. So providing detailed information about, again, whom to call, when to call, and that is all I have. Thank you.
Good morning. My name, can you hear me? My name is Benita Rollins Gay, and I work for Rosecrans. I am supervisor over the Mobile Crisis Department, and what we do, we serve 4 counties too. We serve Iroquois, Ford, Vermilion, and Champaign County. I definitely agree because we see the numbers on a daily basis. We're dealing with suicidal rates of children starting at age 5. And in the 17 years that I've been doing this, I feel like the suicide rate is getting younger and younger, and mostly in your rural areas, but a lot of times in the urban areas. We've started a new program. So at one time, we were training police officers, Urbana and Champaign, Rantoul, Parkland, to be able to assist us with crisis intervention and our 24-hour crisis line. So we developed a program called Co-Responders. And so we actually have social workers who are housed in the police departments. Urbana and Champaign just came on. University of Illinois has their own co-responder. So they will go out with that officer and intervene, do the risk assessment with them, and link that individual to the services that they need. We also developed a program called the Living Room. So we took a part of our building and made it into a living room, which has snacks and juice. They ring a doorbell and they come in and they sit, and a lot of times they're homeless and they're hopeless and they need intervention. They need therapeutic knowledge to assist them with just their daily lives and what to do, somebody just to talk to. So those programs have grown. With our mobile crisis unit, we do a risk assessment. We do an IMCATS to find out what factors are causing them to want to be suicidal or homicidal. We also then, we either hospitalize, and I am one of the ones that make that decision if a person is going to be hospitalized or if I'm going to deflect them and let them go home. And within that deflection, we coordinate a safety plan. That means we give them, we let them give us what they think they need to keep them safe till they're linked to that psychiatrist or counselor. The hardest part, we have a counseling department, but a lot of times we have a waiting list. It's hard to find counseling for them, so we've been reaching out to do counseling, because a lot of times they come with no counseling. A lot of times we're getting families from the domestic centers, both Champaign and Vermilion County. I can say our program has grown. We will be taking on 3 more counties in January, and also we're starting to take the paths, which you'll learn about later. It's going to be a 988 number that anybody can call, and we will be the ones actually orchestrating the 988 number in this area. That's Rosecrans. Oh, I want to say also we got 60 sites. So we do outpatient and inpatient. My region is called Rosecrans Central Illinois. We do have an outpatient unit and an inpatient. Both substance, we have a recovery center that is 20, and most of those people were suicidal and needed help in recovering over substance abuse. And that's 28 days, and one is in Champaign. We have some in Rockford and Chicago. We have substance abuse for children. Then we also go on the psych units, and we assess individuals to see if they still need medication monitoring, medication education. They need still some individual, some group therapy. So we have what you call crisis residential center, and they stay there for 2 weeks, and this helps them get back into the community. So that's Rosecrans.
In 2014, I took the job as Executive Director of Vermilion County Mental Health 708 Board. Shortly after I took that job, Lori DeYoung, who's a social worker and clinical psychologist in the area, called me and said, "Jim, we just had the 4th completed suicide of a recent high school graduate from Oakwood." She said, "There's 4 in just recent years." Lori said, "I know all these kids. My kids know these kids. I know all the families. We need to do something about suicide in our community." So Lori and I started making some phone calls. We gathered together a group that at that time we just called the Suicide Prevention Committee. We started talking about what we could do to help address the problems that existed in Vermilion County. After we'd been working for about a year, we became aware of a grant that was available through SAMHSA, which is the Substance Abuse and Mental Health Services Administration of the federal government. At that time, Aunt Martha's was a part of that group that was meeting, and they took the lead on writing the grant with getting information from all the other members of that committee. We were successful in getting a 3-year grant that covered a 4-county area. So through 2016, 17, and 18, we trained over 2,000 people in Ford, Iroquois, Champaign, and Iroquois, Vermilion, Ford, and Clark counties. Toward the end of that training, Beth Bray Connect and I, who are the instructors here, were given permission by SAMHSA to go be trained in the adult curriculum. SAMHSA does a ranking system for the grant recipients, and their ranking system placed our program at number 6 out of 88 across the country. So we felt pretty good about what we were doing. After that grant ran out, we applied for another grant. We were unsuccessful in getting that one from SAMHSA. All the recipients of that particular grant were north of I-80, and nobody south of I-80 was a recipient of that particular grant. But we were able to get funding from the Vermilion Healthcare Foundation. We've gotten funding from Gibson Area Hospital. For the last 2 years, we've been getting funding from Vermilion County to continue the trainings. So over the course of our work in doing the mental health first aid trainings, we've trained over 4,000 people to be mental health first aiders. Everybody in this room, with the exception of one little girl, is eligible right now to sit in and take the training. There are some people in the room who've gone through the training, and if you have, would you raise your hand? Look around you. If you want to ask them questions about how this training goes, please feel free. It's not just me bragging about it. But we do a good job in the training. We know we've saved lives because the trainees have gotten back in touch with us about contacts they've had and how they've been able to use our training. At the end of each of the rows of tables, there's a stack of sheets that's got the schedule for the rest of this year. For the most part, we do the youth curriculum on the first Friday of each month at the Health Department building. On the third Friday of each month, we do the adult curriculum. Every once in a while, because of a holiday, it might be a different date, but we're setting the schedule for next year as well. And again, it's going to be the first and third Fridays most of the time. But we are also able, if you have an organization, a school, a community group, a church group, a group of coaches, if you have 5 to 8 people that you can get together, we'll bring the training to you. Because we've been able to get the grant, it's at no cost. So every participant gets a 200-plus page manual. You're also certified through the National Council on Behavioral Well-Being. And we can get CEUs if you need professional continuing education credits. We tell people, people a lot of times get trained in American Red Cross First Aid or CPR. This is CPR for the brain. And the training is not just intended for people who are professionals. It's not just intended for mental health counselors and social workers. We've had grandparents take the training. We've had farmers and farmer helpers. We've had people all across the board in all sorts of different occupations and educational backgrounds. I tell people we have to keep it simple because I have to be able to understand it in order to teach it. So we don't do a lot of fancy jargon. We try to break it down to make it useful. The only negative, I think, is it is a full day of training. But if you have an organization that can't give us a full day, we'll break it down into smaller segments. We know it's working. We know that lives have been saved because of people who've gone through this training. And we'll continue to do the training as long as we can find funding to do it.
Some statistics, obviously, numbers are, I didn't expect to see the numbers at the rates that I saw them. It's the 12th leading cause of 5 to 9-year-olds of death. The 12th leading cause for 5 to 9-year-olds. 10 to 14 is the second leading cause of death, and 15 to 24 is the third leading cause of death. So I guess my question to Dr. Lisa, Zachary, Stephanie, Laura, you've been working with kids for, I'm assuming, a long period of time. Suicide rates went up 30% between 2000 and 2018. Are you seeing new things that maybe when you first started out that you weren't seeing before, that you are seeing now? Maybe Stephanie with the college age group, Lisa with the school age group, Zachary with your youths. If you could speak to any changes you're seeing, if there's things that we're missing. Whoever would like to start.
Change in social systems, or
Okay.
in support systems. For many families, there's, for lack of a better word, a breakdown. And there are many components that go into that. The other thing that I see is a change in how people are coping with things, or the coping skills. So those are a couple of things that I see.
Oh, I could talk about this subject today, because I have a lot to say about what's missing, especially in Vermilion County, but one of the consistent areas. So I'll just give you a little bit of background. I was raised in the great state of Ohio. Sorry, but I was. If you are from Illinois, close, but not Ohio. And when I was growing up, we had a lot of primary prevention programs. So some of you probably remember the DARE programs and the Just Say No programs. So we had those in Ohio as well. And so back then, all of the police cars had Just Say No. The police were very active in our schools. And so when it came down to smoking, you know, they had primary prevention programs, because back in the 70s and 80s, and that's what I mean by dating myself. We had all those programs in place, and we had a anti-cigarette smoking campaign as well. And so when I am in the schools, and I had the pleasure of working in District 118 last year, and one of the things that I see for all of the students that, you know, we SAS, the Crisis Service for Individuals that may need hospitalization. I'm sorry, I'm freezing.
Sorry about that.
So I'm stumbling on, you know, sounding shaky because I'm freezing. One of the things that I saw missing was not just funding, because funding is huge, but programs are missing, which require funding. So we were missing programs that dealt with the kids in the area, for some of them who did not qualify for inpatient hospitalization. And so we would have to send them home with their parents, and parents aren't always equipped to address the needs of their children who have suicidal or homicidal ideation. So it was kind of this response from the parents, you know, well, then what do we do? And what services do we have in Vermilion County? So even if we gave a laundry list of, you know, resources for parents, the truth is that they're not going to follow up. So it needed to be done within that crisis, and it didn't happen. And the other thing that I think is missing is that in this area, one of the reasons that I stay is because I've been told numerous times that, and it kind of piggybacks off of what you said, that there were no clinical psychologists in the area. And I didn't believe it until I Googled it, and I thought, my God, I can't leave the area, you know? And so there are a lot of things missing in line with even the clinical interventions, and those things concern me about Vermilion County. So that's what I have to say about it.
So with regard to the biggest changes that I've seen in the children that I work with, or the teens and young adults, certainly an increase in suicidal ideations. From when I started in the field in 2011 to now, there's significantly more anxiety. Kids are just incredibly anxious. And a lot of that has to do with feeling unsafe. There is a lot of suicidal ideation and anxiety surrounding feeling unsafe in the school setting. The breakdown of everything for 2 years due to COVID has created a lot of anxiety in kids because their structure completely fell apart. And then the other thing that has sort of jumped out to me more recently over the past couple of years is that kids are afraid to talk to their parents. Reoccurring theme is that they don't want to make their guardians or their parents worried, so they don't want to share that they are feeling suicidal or that they're having urges to self-harm because they don't want anyone concerned about them. And so a lot of that remains hidden and secretive, which in turn is a cycle and increases the anxiety and then increases the need for help.
So I also had a couple of points that I wanted to share related. So I very much agree, you know, with what has been shared. Some of the things that I have noticed in my role as family therapist, specifically with the intensive placement stabilization program, working with DCFS involved youth, is an increase in the number of referrals. So there's certainly high need and definitely a prevalence for youth who have experienced complex trauma histories. And specifically, our therapists are trained in the attachment, regulation, and competency framework. So really stressing the importance of supporting these youth build secure attachments to caregivers. And I would say that certainly there has been a lot of need around psychoeducation for youth and caregivers. So increasing their understanding of not only how the youth in their care, their complex trauma histories are impacting their current functioning, but and some of the concerns around the development of some maladaptive coping skills, but also really building some psychoeducation around diagnosis, building some psychoeducation around the importance of modulation, so building some supports and structure within their day routine to help youth in their care regulate better. I would also say that I have seen gaps in communication across systems. So we really, again, work hard and stress, the importance of creating a culture of collaboration. So bringing treatment team members together, communicating what the needs look like across the different systems in order to wrap the youth and family with supports and services, having, again, a clearly defined safety plan for the youth in the home, also the need for caregivers to also recognize, their own needs as caregivers. So building in a lot of supports specifically related to self-care and how, we as adults, need to take better care of ourselves and what that looks like, and individualize, those strategies and have them somewhere where that's easily accessible, and that we know, who our support persons are and how to access, resources in support of being a support to the youth in our care. So yes, that's some of the things that I have noticed throughout my time in that role.
And now I have more questions. One for Sasha, and then I have one I would like to direct to Sarah from the VA and Zachary once again. Are you seeing changes in medication regimens? I feel like this microphone isn't working. Medication regimen changes? Are kids using less or more pharmaceutical treatments?
I would say we are seeing children be put on medication at younger ages than what we did years ago. I think some of it might be necessary, but a lot of it is cultural and social. And so the environments of school and the resources that they have for before and after school programs, like kids are under a lot more pressure to be a little more robotic and to follow strict regimen of like arriving, and I think recess and outdoor play and those things have created more problems and rise in children who look like they might have ADHD and they really don't, so then they're put on medications and maybe some of that isn't really necessary, it's more social. But I think we are seeing more kids have anxiety, and so those kids are placed on medications at younger and younger ages because their ability to cope and adapt to the stressful environment and the changes that they've gone through with COVID, being isolated and not being able to socialize, and then thrown back into school where suddenly they're terrified of all of the people and the noise, and they're overstimulated, and it's a lot to manage, so they don't cope really well, and they don't have access to good resources to learn appropriate coping skills and how to process all that. The easy solution is to put them on medication. So I think some of it is probably necessary to manage some symptoms, but I think a lot of it is because of all the social changes that have happened and a lack of learned resources and coping, that it's a quick go-to. I mean, there's a million commercials of take this medicine and your life will be happy. So every parent goes in, even to their pediatrician. I worked pediatrics for 7 years, and there's so many children who came in, and the parents didn't know what to do with them. They didn't know how to help manage coping. They didn't know how to navigate the stressful times, like of just normal childhood development. So you can just give them a pill to make them calm, or give them a pill because I don't know what else to do with them. And therapy services, depending on your insurance and availability, isn't always easily accessible. So there has been an increase in medicine, yes, I would say, but I'm not sure if all of it is necessarily warranted. I think there's a lot more to do with it.
I was just gonna jump off that for a second too and say, parents are more willing to put their kids on medication now, I feel like, than they were even, 5-6 years ago. I don't know if that's a cultural shift or what, but it seems, at least in my experience, that parents were more resistant, not wanting to start their kids on medication yet. Let's try other things first, versus now, what medication can I put my kid on? We need to fix this right away.
So my next question is for Sarah. So between 2019 and 2020, suicide, veterans who committed suicide increased from 26.3% to 28.7%. Is there something that, if you could maybe talk a little bit more to, I've never served in the military, what individuals who may have family members that have served in the military or veterans that may be suffering with certain conditions, what do we need to know?
Okay, so I think one of the really important things to know, healthcare in general kind of took a hit for workers. I think every healthcare agency is struggling, so the wait to get into therapy and psychiatric services has gotten even longer in the community. And while the VA hasn't been immune to that, because we are kind of a specialty niche and we serve a smaller group of folks, we have better access generally than in the community for mental health services. So if you are a veteran, or if you have a friend or family member who's a veteran and maybe they've never enrolled in the VA or aren't sure if they're eligible, I would just really encourage you to encourage them to come talk to our eligibility department to see if they do qualify, because we have same-day access to mental health services. You can just walk in and see a prescriber or a therapist, and that's practically unheard of in the community. So the resources are there since we're federally funded. We have a variety of, work therapy services or vocational rehab to help veterans find work. We have an entire team of homeless specialist social workers that can help find veterans housing. We have a substance abuse program. We have an inpatient program where veterans can stay. Typical length of stay is about 3 months, where they can reside and get mental health treatment, including post-traumatic stress disorder treatment. They can get lined up with housing and employment. We have a whole host of services, and really those services are aimed to increase protective factors so that people don't turn to suicide, right? We know that some of the risk factors for suicide for veterans are things like homelessness, not working, unemployment, legal issues. We have a Veterans Justice Outreach social worker that can help veterans with legal trouble. So VA does a nice job of kind of developing these programs to help increase protective factors and decrease risk factors for our veterans.
Excellent. And this one goes back to Zachary. So in your bio, you shared with us that you work with the LGBTQIA and gender sexual identity issues in your client base. And according to the CDC, grades 7 through 12 that are in this group are twice as likely as their heterosexual counterparts to commit suicide or have suicidal ideations. Are there things in our therapeutic world that, outside of the normative, that we're not looking at or working with, or how would we help this particular group? It's kind of a loaded question, sorry.
Yeah.
It's a very loaded question.
So I'm going to answer that kind of broadly. I think any time that you do not identify as a traditionally, as like a traditional group, okay? So anytime you are other than, I guess, you're more isolated and segregated. And so the isolation is twofold, and then that is, first of all, where the suicidal ideation comes into play. And second of all, we know that there's increased risk of suicide in LGBTQIA and trans-identified youth, largely because there is a lack of acceptance. And so while society and families and things are becoming much more progressive and moving in a more progressive manner, we do still live in a society where, being identified as other than can make you be targeted and feel isolated. Largely with teens, that's also increased with things like impulsivity. So they have a bad day and you go home and do something to hurt yourself or kill yourself, and it's a in the moment thing. It's not always thought through. But so I guess to answer your question, I would say be supportive.
Okay. Excellent. So I have one question for Stephanie. Stephanie, I'm just figuring out this technology. So you've been with DACC in the advising world for a number of years. So I'm sure you come across students from different economic backgrounds, race, gender, even international students. And someone had mentioned earlier that not only are there biological and medical things, but there are also social and cultural things. Mm-hmm. Do you see that occurring in your work with a broad range of students? That are there cultural differences in seeking help and sharing?
Absolutely. Speaking for the African American culture, just in general, it hasn't been, seeking therapy services has not always been readily acceptable by, or encouraged by family members. It's always been a thing where what happens in this house stays in this house. So you didn't talk about your issues and problems, and you didn't talk about things outside of your home because it was taboo. So with that being said, you're not going to seek someone for therapeutic services. You're not going to maybe talk to a neighbor. You may or may not talk to a friend, but for the most part, what happens in your home stays in your home. So that, could carry on into, college college life where, you know, you're having issues. Maybe you're talking to your friends about it. Maybe your friends don't know of resources. And by talking to your friend, you know, you're expecting that information to stay with your friend. So you don't get the help that you're needing. So I have had students come into my office many times who have difficulties talking to me about things just because culturally, that's not what we do. We don't talk to strangers. We don't talk about what's happening in our home. So I think just getting more awareness out, getting more information out to help students and to help the community access resources and to let them know it's okay to talk to people, it's okay to get the help, is what's been interesting and can be challenging.
Thank you. So I have two new questions. I just keep coming up with new questions here. One is going to be from Anita. Urbana School Board, you were elected in 2005 and served until 2019. Are these conversations occurring at the school board level with prevention, intervention, mental health services?
It did. It became a big issue in 2017 concerning suicide. There became groups of kids that when one became we call them a pact, when one became a self-harmer, the others. So, and it was really with that age group, I would say 10 to 14, the middle school age. And so it was high suicide ideology and suicide prevention programs then were starting to be put in place. More outreach workers were sent out into community because of so many risk factors. We had a lot of people, environmental, about 2% domestic violence started to be on a rise. More because Champaign-Urbana with the university, we became a mobile unit. So you had people of different cultures intertwined. So you had a lot of gang activity. So the bullying increased. And we had a lot of kids that they felt hopeless. They felt not recognized. So yes. So then I started working with them after COVID because studies need to be done. It got worse. The pacts increased as far as not only self-harming, but one wants to kill themselves, the other wants to join them, or because that's my best friend. So yes, I see it. I saw it then, and increasingly now I see it. I taught school in Ohio for about 17 years also, and none of this occurred. Suicide was like 1%, and now in Illinois, and especially in Urbana, it has increased. So it's just, you gotta reach out to these kids, and what Jan said, attachment is the main things. These kids don't have that bond with their parents, and they feel unloved, so then they reach out for it in the wrong ways. And then when that's not accomplished in the school environment, they feel hopeless and worthless when you talk to them. And those are your kids. And so also the LGBT, we increased that too, because of a lot of those kids were made fun of at one time. So then we started counseling groups with them to make it better.
Okay. I have one question two questions for Dr. Lisa. I'm noticing in your bio, behavioralism is one of your theoretical orientations. My students found it really interesting. We'll see if they're still awake, about Skinner's Pigeon Missile Project. Do you guys remember that one? B.F. Skinner tried to get pigeons to fly missiles. Awesome. As a school psychologist, as you had mentioned before, I have two questions. One, Zachary had mentioned the impulsive nature of young people. This age group between 10 and 24, can you just speak shortly to brain development? Does that have
Sure.
something to do with it? And has the changing of how we do education over the last 10 or 15 years impacted kids' testing, pressure, all of these different things? So
Oh, yeah, those are good questions. I actually like physiological psychology, so that was perfect for me. I know that's weird, right? I do. I like the brain. Yes, just to give you a brief synopsis of the brain in little kids up through maybe 19, 20, the hormones, as you guys know, the limbic system develops much faster than the prefrontal cortex, which you can probably imagine, or you know already what the prefrontal cortex does, right? That's where our executive functioning is there, reasoning. So if you have the hormones and everything that goes along with the limbic system functioning earlier than the ability to reason, well, what do you think happens in the schools, right? I see someone I want to fight, bam, I'm going to go fight. You know, I see someone who's harming themselves because they want out, I want out too, I'm going to do it. The reasoning part, which is delayed, which is why if you're ever in the schools, you'll kind of go, I don't understand how that makes sense to you. And they'll go, me either, I just wanted to do it. And you're kind of thinking, that didn't make sense. And the more you try to reason with the kids, it just doesn't work unless, for me, you go on the behavioral side and deal with the motivation and put the interventions in place to help children. The second part of your question, would you mind repeating?
yes, but, so I'm officially, I can now say, 20 years ago, when I was in school, there was very little pressure.
Oh, yeah.
And that doesn't seem to be the case with my 7-year-old. So.
That's right. Gosh, you know, I can answer that from a personal opinion and also as a psychologist. So as a psychologist, testing has increased. Most of you know that your professors are constantly testing you on different things to assess the kind of knowledge. The first thing that my own kids had to do this year when they started school was to take NAP testing. And my thought was, why are you testing kids the first day of school? Does that make sense? It doesn't make sense. So testing has increased in the schools. These kids are stressed out when they have to do testing. We are testing more kids, but unfortunately, we don't have enough people to test the kids. So then you're stressing out your mental health professionals, especially your school psychologists. The pressure to perform is huge in the schools. And so what you're seeing is an increase in anxiety, as some of my colleagues have mentioned. You are seeing an increase in mood disorders, so major depression, disruptive mood dysregulation disorder. You're seeing an increase in bipolar 1 and also bipolar 2. And I'm starting to see some kids that have symptoms of personality disorders. Even though you really don't use those on kids, you can kind of see some of the projection occurring. So I do think that there are far more stressors. I don't remember being tested the way they're testing kids now. You don't remember that either.
No, I always tell my students, I knew we were getting tested when they gave us a granola bar and orange juice.
Yep.
It's like, there's the next 4
Or they were gonna
hours.
make you take that mouthwash where your teeth turn red. One or the other.
And they started testing Eleanor in kindergarten, and
Yeah, I
they
don't
sent objective
understand.
measurements home, which I wonder from a brain development, how do you objectively test a 7-year-old? But and then one of the things I'm going to kind of jump off of kind of what you were talking about, seeing different things, pressures. When Zachary, I believe you said worried about telling their parents because they worry. Is it like cascading anxiety? Like parents are anxious, kids are anxious, teachers are anxious, friends are anxious, that we just have kind of like this waterfall of anxiety. And
Oh, yeah.
no one really knows what to do with that.
Oh, yeah.
Absolutely. I mean, I'm not sure that there's much more that you could say about it. There's just, the system is broken right now. I mean, the education system, I think, is broke. I mean, the kids are anxious, their parents are anxious, the teachers are anxious. You know, there's not enough staff anywhere. There's not, there's just, people are,
Especially after COVID.
yeah, I think after COVID, people just started sort of,
Overall, the stress tolerance has just gone down. You know, if we can kind of collectively learn that we're not always going to be comfortable, right? We're going to be in hard situations. We're going to feel uneasy. We're going to feel anxious. We're not going to like it. But that we do have the strength within us to cope with that and get through it and overcome it. I have had a panic attack in the past, and you know, when you're in the middle of a panic attack, you feel like you're going to die, right? That's the, oh my God, I can't breathe, I'm embarrassed because people are looking at me, and you think you're going to die, but you're not. And so once you kind of realize that, I think for me it really took the power out of it and the fear, and I realized like this isn't going to kill me. I may wish it did at the time, but once that gave me power, and I was able to kind of overcome that. And I think when we shield kids in particular, if the child is anxious and doesn't want to go to school, and we feed into that and say, okay, you can stay home today because you're anxious, or you cannot go to practice today because you're anxious about it. I think we may have good intentions as parents, but really we're not doing them any favor. They need to do the hard thing and see that they can do the hard thing and get through it. While it may have been uncomfortable at the time, they were able to come through that. I think.
One of the things that we don't talk about, though, is the stress on the helping professions, on the teachers. I've got 4 teachers in my family. They've gone through things in the last 2 years, COVID-related, they've never had to face before. Now they're going back into the schools, and the kids have been out of school for 2 years. The kids don't know how to relate to each other. On top of that, they're trying to catch up. The teachers are trying to catch the students up. The students are trying to catch up. Then on top of that, there's estimates that 40% of the American population is being affected by, not necessarily a diagnosis of, but being affected by symptoms of anxiety or depression directly related to COVID. That's 40% of the population. Now, I've done 2 trainings for different county departments in the last couple of months to help the staff deal with people who are coming into their offices and who are blowing up at staff when the staff is there to help them. It's almost like our fuses have been cut in half and then cut in half again. And we need, as a society, to start trying to figure out how we decompress from all the stuff we've been going over and going through in the last 2 years. But it seems like for some in the helping profession, instead of having an opportunity to blow off some steam, there's even more and more pressure because there's fewer people going into those fields. So those of us who are left are having to work longer and harder hours trying to serve more people. And it just keeps going.
Excellent. So I am going to open it up to see if anyone has any questions for the panel. If there's any specific things, we have a few minutes. If not, then I do have more questions for the panel. If you guys don't have any questions. Not all at once, okay? Not all at once.
I just wanted to say
Okay,
something.
yes.
Just from a personal opinion, and, you know, Jim and all of you, you know, what's different from, you know, we talked about 20 years ago. I think that we kind of had the perfect storm here with social media making the world smaller and COVID making us more isolated. But especially in social media, you know, although the world has become smaller, it's become a meaner place. I didn't have to worry about cyberbullying in the 70s when I was growing up. I graduated high school in 1981, and I'm a Buckeye. Also, I just wanted to put that out there to my Buckeye buddies.
She gave me her card.
I married a guy in the Army, and that's how we ended up back here when I was in the Army. But, I chose to live here. When people say they hate it here, even being 22 years in law enforcement, as a police officer, I noticed that, and it was really since 9/11, I can point that out as like when I started to notice anxiety increasing in children. When you have a news cycle that's 24 hours a day showing things on television that you didn't see when you were a kid. We watched Saturday morning cartoons. We weren't watching CBS News, nightly news. We weren't watching CNN
And
being embedded when we had a war, and all those stressors that are put on kids. So not only are they just, now the world is smaller and meaner, but now the news travels so much quicker. So the whole thing about school shootings, there were school shootings at Moses Lake, Washington in the 1990s, people. This is not a new phenomenon. It's just now it's just so much more prevalent, and it seems to the news gets faster to kids than it did before. And we didn't have cyberbullying. We didn't have any of that stuff because we didn't have phones, and I didn't have a cell phone when I was a kid.
We didn't have technology.
And people are meaner, and even adults, and then that's why more adults have stress. Everybody who has Facebook, Instagram, it's a highlight reel. You're not showing your problems, you're showing how great your life is. Well, then now we have all these kids and adults who are comparing their lives to those people going, oh my God, I don't have this in my life, or I have a horrible life compared to that. No, you don't, you just don't see what those people are going through. So I think that has a lot of impact. We just have had a lot of things in the last 5 years really impact kids and adults. And and you guys are witnessing that and having to really midstream reverse or chart a new course or an unknown course. So all of you who are out there studying behavior, sociology, or psychology, there's so much more that we have had to react to, than you have had to before. And I have seen that in my own family, personally and professionally. And I just wanted to put that out there because I think that makes it so much different than what it was when I was a kid growing up in Cincinnati, Ohio.
Okay.
I didn't, I didn't have that. I didn't have that pressure. We ran outside and played outside. My grandkids sit in the house and play video games. What kind of exercise are they getting? No wonder they're getting kind of chubby. We're not making our kids go outside and hey, see you when the street lights come on.
Mine have to be
But
by the street light.
yeah, when they come to our house, it's like, hey, you aren't playing your video games. Guess what? We're going to go to the park. It's just a different way, that we were raised and that our children.
Yes. And
Hopefully, we took all the good things from our parents and have been. But you know what? We took the bad too. The whole thing about it's a generational thing too. It's not just an African American thing.
Right.
Where
And-
we don't
and-
talk about. You don't talk about being crazy, or you don't talk about you need help. What do you mean you need help? Go to church, talk to the priest, or
Yeah.
or you don't tell your friends.
Or
You don't
take
tell
some
your
Tylenol and rub some Vaseline on it.
put some Windex on it, and you're good.
Yes, great stuff. Yes, I think we could have an entire 3-hour panel on just social media. One of the things, going back to what Dr. Lisa said, is the information you receive and what your brain is actually prepared to process are not necessarily always conducive with one another. So I wanted to turn, we have about 10, 15 more minutes. Does anyone have a specific question, something they'd like to share? I feel like, yes, in the back.
What do you guys see from when you guys were growing up and what we see with families today? How do you think having the support from family or aunts and uncles when we had tended to stay more in contact and in touch with each other back then to the effect that it has nowadays along with what we're seeing with kids wanting, parents being like, oh, just put them on some meds or not asking for help. That you guys see a correlation between some of that from then to now?
I do. I think the gap here is parenting, you know. When I was little, everyone disciplined you, even if it was your neighbor. I knew I was gonna get in trouble if my neighbors knew. We didn't hold secrets when we were little. So if we didn't feel good, or if we had a challenge with someone, or the green lady, who was huge when I was little, mental health, you know, we talked about it, our neighbors knew, and everybody was on board, including our family, with getting us help, the community. And I think the community saved us, including me. And I think that's what's missing. People want to keep quiet when they hear about things, and they don't tell anyone. So if I can offer any advice, it would be, if you hear about these things from your friends and your colleagues, our teachers, tell them it's okay to tell someone, because that's what all these trained professionals are for. People have a stigma against mental illness, and we need to change that, because we are suffering with the suicide rates going up.
But I think we've created a culture where what I hear, especially the teenage population say, just yesterday I had one tell me exactly what Zach was saying. She didn't want to talk to her dad because her dad already had too much going on. And we've almost glorified busy, and everyone is just so busy, and we're like, everybody has 20 million things to do, and we act like that's fantastic, and I'm so busy, and I've got all these things to do. Well, your kids hear you say that, and your kids hear how stressed out you are, and a lot of that is self-inflicted. Like, stop doing so much. Like, just stop. You don't, and your kids don't need to be doing 25 things. They don't need to be in every sport, and they don't have to be perfectionists, and that's where we've created the stress and the anxiety by making people do more and signing up for more and taking on more than you actually emotionally and in your physical time can do, and that's directly impacting the children. And they see you're too busy. Well, you don't have time to talk to me, then we won't talk about it. I'll wait and tell somebody else. And we've lost, going back to that, the family question, we've lost that village. I feel very fortunate that I've got some people, even if they're not super, super close, like even sitting out here, that I have people that when things are like crazy happening, I know I can call them, and I know that I can say, hey, like, my kid's broken, so I need you to fix her. That you need those people, and even if it's not blood family, you still need your village, you still need your people, and we need to get back to that human connection and that support. And then I just want back like 2 questions ago about the children. I've had 2 kids recently, since school has been back in, that the anxiety and kind of trauma response has been elevated immensely because we are now practicing active shooter trainings in schools, and this is terrifying for kids. And I get it. I get why we do it, because we're trying to say, hey, be prepared. If this happens, how can we save your life? But I think that a lot of that needs to happen with the teachers and the grown-ups alone, and that we need to look at some of what age, like does a kindergartner, how much information do they need to actually know about what could happen to them? Because now they're terrified. And now they're afraid people are going to come in their windows at home at night. But there are bad people who come and they will shoot you. They told us at school. How much do they need to know? They need to be prepared. A bad thing can happen. How do we stay safe if there's something bad? But we have to try to limit and regulate some of that information by age and development, because it's too much. And now I have a 6-year-old little girl who's completely traumatized and can't sleep. Because she just went to school and her parents didn't know they were going to do an active shooter training, and it just happened, and now her little brain can't keep up. So I think there's some social things that are big, and we have to balance safety and protection and prevention and information with damage control.
Yeah, I mean, I have a 7-year-old, and yes, they've done, active shooter drills, and, I always think of it this way, 5, 6, 7, they still believe in Santa Claus. Their imaginations run wild without any bumpers. And it's very easy for them to imagine a world in which horrible things can happen. And so, yeah, it's a whole other realm of information. What can I take in and what can I process? And, I look at, her school and I'm like, oh, well, no one can get in without being buzzed in. All the doors are fob protected and locked down. But to her, it's like they could just open a window that I know is welded shut.
That's right.
So, yes, and we could spend hours on that topic as well. So I just wanted to thank the panel for coming. I appreciate all you guys coming. I love the fact that you mentioned the village. One of the core concepts of the Connection Cafe is to bring people together. And I feel that is one of we are so used to not being around each other. And I don't know if there's an easy way to reset that. I was even, making coffee when everyone's kind of out there. I didn't used to be anxious around people at all. And now, sometimes if there's more than 5 or 10 people around me, I can feel anxious. And I hope that is something that will dissipate away. So thank you for coming. It's greatly appreciated. Thank you for the panelists. I will probably email out a survey if you guys would like to fill it out, and we will go from there. So thank you.
Thank you.